Hello again, everybody. Our topic of discussion in this lecture is going to be atopic dermatitis, which is one of our allergic diseases. So here we have a 5-month-old baby boy who is presenting to the clinic with his mother complaining of a recurrent itchy rash. Mom says that the rash has been coming and going since he was about 3 months old and typically is concentrated along his cheeks and around his mouth. The rash tends to clear up on its own, but she has used baby lotion in the past and is unsure if it's helped or not. She denies any fever or other noticeable symptoms accompanying the rash. He has not ran a fever, I already said that, and has otherwise been well. She is unaware of any sick contacts. He does not attend daycare and has no siblings. Family history is significant for type 1 diabetes in mom and asthma in dad. On exam, you note a healthy appearing afebrile boy who is tracking normally for height and weight. Vital signs are normal. Physical exam is significant for an ill-defined scaly erythematous rash over the cheeks and the perioral region. There is a similar but more mild rash along parts of the trunk and the antecubital fossae bilaterally. Lungs are clear to auscultation. Abdomen is non-tender, non-distended with normal bowel sounds. Neurologically, he is grossly intact. So, of course, this patient has atopic dermatitis. We get that just based on the name of the lecture, but this is a child with a rash, and children with rash, it can be so many different things, and you should be aware of that. It's a nice long differential diagnosis, but there are some things that point to atopic dermatitis. Any child, or really anybody, who has a recurrent itchy rash, they tend to have this eczema or atopic dermatitis. Now, atopic dermatitis will initially present in a young child, younger than 2 years of age. Now, that doesn't mean that you're going to be making the diagnosis for the first time in children that are under the age of 2 in all cases. Certainly, you can have an 8-year-old or even an 18-year-old who has had a recurrent rash and has never been diagnosed with eczema before, and we're just diagnosing them for the first time. However, what you should know is that this is something that starts out very early on in life, and it's going to continue intermittently throughout life. It tends to get better with age, but it starts out very early on. So he's had this since he was about 3 months of age. Like I said, this is an intermittent rash. Even if you don't treat it, it will come and go. Now, you can have areas that are more affected than others, and you can have areas that sort of remain affected longer, especially as you get later on. You have chronic atopic dermatitis, which is characterized by this lichenification we're going to see. But the acute rash, which we see in this child and what we see in very young children, the acute form of atopic dermatitis, this red erythematous swollen rash, it's maculopapular in appearance, this will come and go. This is not going to remain like this even if you don't treat it. We also note some other useful things that he hasn't run a fever. You're not going to have a fever with eczema. He's otherwise well. That's going to be important for a reason that I will tell you when I'm done going over this. And then she's unaware of any sick contacts. She doesn't have any siblings. Then the family history. So if you're thinking this is possibly atopic dermatitis, you want to have a family history. You want to have a family history no matter what, really. But you want to have a family history, and you want to know, are there any family members, particularly primary relatives, first-degree relatives, mom, dad, siblings, are there any primary relatives with signs of allergy? So by allergy, I mean atopic dermatitis, asthma, allergic conjunctivitis, allergic rhinitis, food allergies, and indeed we do see that dad has asthma. Remember that if you have one parent with an atopic disease, your risk is 50%. If you have two parents, it's about 66%. Otherwise, he appears normal. You have this rash. Typically with atopic dermatitis, it's going to be scaly. So it's going to be an itchy rash. You'll see some scaling in some cases if you look closely enough, depending on how long it's been going on. Classically, in very young children, the rash will be on the face. It can also be on the scalp. And along the mouth and along the eyes. Now we see in this child not so much along the eyes, a little bit around the mouth, but you will see the cheeks most prominently affected. Otherwise, he's normal. So if there's anything in our differential that we may want to consider here, this is a pretty straightforward diagnosis, but if there is anything in our differential, one of the things, maybe you thought of it, but one of the things that you might want to consider, even though the history really kind of rules it out, is fifth disease. And fifth disease is a syndrome that occurs generally once in a child's life and it never occurs again. Unlike in this child, where this has been a rash that's been coming and going for a few months. Fifth disease will typically present either with the rash or with constitutional symptoms early on. So the way that fifth disease tends to progress is that they have a low-grade fever, headache, cold-like symptoms. That goes away, and then 7 to 10 days later, they show up with this erythematous rash, most prominently over the cheeks, which we see also with atopic dermatitis in very young children. It's most prominent over the cheeks. In addition, with fifth disease, they can also have the rash over the trunk and the proximal extremities, but the nasal area, the perioral area, and the periorbital area tend to be spared, as well as the palms and soles. But the rash can also itch too. The one thing that helps us rule out fifth disease in this child is that it's been a recurrent problem. It's not a one-time problem where there was fever, constitutional symptoms, then gone away, then a rash. Fifth disease will also be self-limited, so it will go away on its own. So there are some differences here from fifth disease. There are some other things in our differential, but we're not pointed in that direction just based on the fact that he doesn't really have any other serious symptoms. Now, if, for instance, we had a 5-month-old baby boy, same exact presentation, but he's had recurrent history of otitis media and sinopulmonary infections, then we are going to do a CBC and look for the third part of that triad. Where do we see it? Wiskott-Aldrich syndrome. And we would look for low platelet count. So Wiskott-Aldrich syndrome, remember, is a immunodeficiency, and the triad is the immunodeficiency, which is an immunodeficiency towards, particularly towards the encapsulated organism. So you have sinopulmonary infections, ear infections, and then they also have this, it's not atopic dermatitis, but it's an eczema-like rash, and then they'll also have thrombocytopenia. We don't see that in this child. He is normal, healthy otherwise, so we're not concerned about that here. But Wiskott-Aldrich syndrome is something that can present with an eczema-like syndrome. We're going to briefly cover the epidemiology. We'll talk about the pathogenesis. I'm not going to go into it in too great of detail because the pathogenesis is poorly understood. The clinical manifestations, which we've already kind of talked about in this vignette here, how we go about diagnosing this, it's clinical, how we manage this, which is where I want to spend most of the time talking, and then the complications and prognosis. Atopic dermatitis has a prevalence of about 10 to 12% in children and then 0.9% in adults in the United States. So you can see that it is a pretty significant prevalence in children. This does tend to remit or get better, at least, as these children age. So most adults, even if they had a history of atopic dermatitis as children, most adults will experience at least a 6-month symptom-free period, even if they're not getting some kind of prophylactic treatment or ongoing treatment. As with most allergic diseases, the prevalence is higher in developed countries, and the frequency is also higher in patients who immigrate to developed countries from developing countries, if you compare them to patients that remain, people that remain in developing countries. So you immigrated from Bolivia, or you immigrated from Vietnam or Uganda, and now you're in the United States, you have an increased risk. If you're a child, you have an increased risk of developing an allergic disease compared to if you had just remained where you were. There is a slight female preponderance in atopic dermatitis, approximately 1.4 to 1, so not really significant, but it's there. 80% of diagnoses of atopic dermatitis are made prior to age 5, and 95% of patients will have had symptoms prior to age 5. So we don't always make the diagnosis, especially if for one reason or another the child just doesn't go to the doctor very often, or if the symptoms were very mild. The diagnosis may be delayed, but 80% of the diagnoses are made prior to age 5. There is a small number of patients who will develop atopic dermatitis for the first time as adults, but that number is negligible. We talked about in some of these other sections about the atopic march theory, and that basically means that these patients who develop atopic dermatitis or allergic rhinitis, it may progress into more severe allergic diseases such as food allergy or asthma. And it's not the disease itself progressing, but what we think is that there's this underlying cause that's giving rise to these various disorders. And atopic dermatitis is quite unique among these other allergic diseases in that atopic dermatitis tends to present earliest among all of these. So whereas asthma may not present until 2-3 years of age, allergic rhinitis might not present until even later than that, atopic dermatitis tends to present within the first few months of life. The pathogenesis is poorly understood, unfortunately. We have a couple theories, both of which are going to ultimately lead to a defective barrier. So this is ultimately a skin disorder. There are allergic causes underlying it, but it is a skin disorder. Now, there are two competing hypotheses, and both of them have their strengths and weaknesses. One of them is called the primary immune dysfunction hypothesis, where we have an overabundance of Th2 cells relative to Th1 cells, which leads to increased production of certain interleukins. Those interleukins, cytokines, lead to an increased production of IgE, and that can lead to ultimately inflammation and a disruption of the barrier, which is the skin. The other theory, which I find more compelling, is called the epidermal barrier dysfunction hypothesis. And the theory here is that there's some kind of genetic problem that leads to a primary skin barrier defect. So we're kind of working the opposite direction from the primary immune dysfunction hypothesis. So there's some kind of genetic problem that leads to a skin barrier defect, which allows the entry of allergic antigens, and then that allows for the production of cytokines, which then leads to the inflammation. So kind of the reverse. The reason that I find this slightly more compelling is that we have isolated genetic defects in patients with atopic dermatitis, in particular a gene called filaggrin, FLG, which codes for the filaggrin protein. And it is actually 20 to 40% of patients with atopic dermatitis have a mutation in that filaggrin gene. And the filaggrin gene is located on the long arm of chromosome 1. It is also associated with ichthyosis vulgaris, which is a different disorder from atopic dermatitis, but there's a tendency, if you have the filaggrin gene, that you can develop atopic dermatitis or you can develop ichthyosis vulgaris. I'm not exactly sure. It's probably different mutations, but they're both linked to the same gene. And this filaggrin protein, what it does is it helps bring together the structural proteins in these cells to help form tight bundles and flatten the outermost cells of the epithelium, which then forms a nice tight barrier. If you lack this, then it's going to lead to what this article said is a transepidermal penetration of environmental allergens So in other words, environmental allergens can then get into your skin, and then when those allergens are there, it leads to inflammation and potentially leads to this atopic march, where you can develop asthma and rhinitis. Uh, in addition to providing strength for the skin, the barrier surface, filaggrin also is a precursor to a byproduct known as natural moisturizing factor. And this allows your skin to moisten. It also regulates pH. And what we know with patients with atopic dermatitis is that they have a tendency towards dry skin, xerosis. And so this is another thing that makes me think that this is a pretty compelling theory, because this also accounts for the xerosis, which the primary immune dysfunction hypothesis does not. But there are two hypotheses behind this. What I want you to get out of this is that patients with atopic dermatitis, they have dry skin and they have a tendency towards other allergies. Okay, so atopic dermatitis can be characterized into two stages. Acute atopic dermatitis, which in other words are your flare-ups. This tends to be what we see in very young children. We don't see chronic atopic dermatitis until they get a little bit older, 3, 4, 5 years of age or older. So in babies and in acute flare-ups in older people, we see this acute atopic dermatitis, which is characterized by an itchy, erythematous, scaly, and dry papular rash, which tends to affect the creases, so the antecubital and popliteal fossae, the extensor surfaces, and then most importantly, the cheeks, forehead, and scalp. The rash can occur anywhere on the body, but what we do note, and I probably should have included it in this patient's vignette, but the diaper area and the nose tend to be spared. So this stands apart from diaper rash, where if you have a child that comes in with a rash that's on the diaper area, so in the gluteal fold and around the genital area, that is diaper rash. That is not atopic dermatitis. Atopic dermatitis tends to show up on the face and on the extensor surfaces and on those creases. Now, because atopic dermatitis tends to be itchy, you can note excoriations, and that's just because of the itching. So keep an eye out for that, and make sure that you keep that in mind, because you don't want to confuse that for something else. The itch-scratch cycle does not mature until about 3 months of age, so you're not going to see that in really young children. Chronic atopic dermatitis stands apart from acute atopic dermatitis. This is a later manifestation, and this is characterized by itchiness, dryness, and lichenification. Lichenification is a white plaque, and it's, I believe, caused by collagen deposition from just chronic inflammation in a given area. So if you have a certain area that is constantly or chronically affected with these acute flare-ups, you can ultimately get this lichenification, which is this white plaque that develops over that area. And that's just a chronic inflammatory process. So while the dry skin and pruritus are generalized, lichenification often affects regions that have had frequent acute rashes. Particularly, you're going to see lichenification most commonly over the folds, over bony protuberances, and on the forehead. Very importantly, atopic dermatitis predisposes the patient to cutaneous infections, especially Staph aureus and herpes simplex virus, especially herpes simplex virus 1. We're going to talk about two of the complications that come out of atopic dermatitis, and they both involve one of the two of these. So there's an increased incidence of infection, probably because of the fact that you have a defective barrier. Clinical manifestations. Pruritus is the sine qua non of atopic dermatitis and is also the most salient feature. So if this is not an itchy rash, this is not eczema. Also, the itchiness tends to be the complaint. So if you have a really young child like this baby, then itchiness is not going to be the complaint, because it's going to be mom or dad that's complaining, and they're going to complain of the rash. If you have a 2-year-old or a 3-year-old, mom or dad may come in saying that it's a rash and the child's itching at it all the time. But oftentimes when you have 3-4-month-old babies, they're generally not itching. Like I said, the itch-scratch cycle doesn't really mature until about 3 months of age. So pruritus overall is the most salient feature. The rash is going to vary based on the stage of the disease, so whether it's acute or chronic. In infants, it tends to be the acute version only, not the chronic. So you'll see the erythematous papular rash generally affecting the cheeks, forehead, and scalp. Can also affect the extensor surfaces and the folds behind the elbow and the knee. There can be variable levels of scaling and crusting. You want to keep an eye out for that honey-colored crusting. Why? Because what are one of the complications? Staph aureus infection, and in particular, impetigo. And that honey-colored crusting is indicative of a staph infection going on. In older children, so by older I mean like 2, 3, 4 years of age older, you can note the acute rashes. So you can have acute atopic dermatitis in anybody. It just, with infants, it's can typically be only acute. With children, you can get acute or chronic. And so you can get these acute flare-ups. There can also be the chronic atopic dermatitis, where you can see some degree of lichenification. And that, in particular, will include the flexural creases, the thigh buttock creases, and then, as mentioned, the bony protuberances on the forehead. In children, the neck and flexor surfaces are more frequently involved than in younger children. And then in adults, you can get all of the previously mentioned features, and you can also get this sort of darkness around the neck, and we call that the dirty neck presentation, and that is amyloid deposit. I'm not exactly sure how you get the amyloid. It might be just chronic inflammation. There's also prominent xerosis and lichenification. And it's all going to vary. Some patients have more severe manifestations than others. You can also note the presence of findings consistent with other allergic processes, so asthma, allergic rhinitis, allergic conjunctivitis. You can also get those Denny lines along the lower part of the eyes, and allergic shiners. So here are the areas that are most commonly affected in young children and babies, like we saw in this child. So the face, periorbital area, perioral area, tends to spare the nose. So the nose does not tend to be affected. Forehead and scalp can be affected as well. The elbow and then the knees can be affected too. So you get the extensor surfaces, and then these folds can be affected too. And then you can, to variable degrees, get you can get the rash on the trunk too. So it's not showing all the areas that can be affected. These are just more common. So here you see a child with atopic dermatitis of the cheeks and then the periorbital area. The nose is spared, but you notice how this is very dry in appearance. You see there's some scaling here on the patient's right side, and the papules are really, really small. But there's this sort of dryish color. You may want to get a skin culture and do antibiotics for this child because it looks like there may be some honey-colored crusting, although it's kind of hard to tell with the light. So this is obviously atopic dermatitis. Again, you see a similar appearance. You see scaling, dryness of the skin. You'd really have to feel it to appreciate it, but you can almost see it here. And then you note, again here, this looks like honey crusting. So again, you may want to treat this child with antibiotics. We'll talk about treatment in a little bit. It can also occur over the feet and hands. So we see it here. Usually a little bit older, you'll get this. This is just up close how it looks. So you see it's very scaly in appearance and not very angry looking, but you do have some erythema. So this is a little bit more discreet than what you would normally see generally in most children with atopic dermatitis. in as much as you see it on the left side, but not on the right side. Usually you'll see it'll be a little bit more generalized, but you do see the erythema. It's not a really good picture, pretty low resolution. What you do see here are the Denny lines, so both sides. Here we have, I can't tell, it looks like the diaper here, so this is probably the popliteal fossa, but you see atopic dermatitis occurring here as well. Here's an adult. Maybe not an adult, this might be a child, can't tell. But either way, extensor surfaces of the arms tend to be affected. This is lichenification. So lichenification will happen most commonly over the folds and then the bony protuberances. So you see this sort of whitish discoloration. That's lichenification. It'll be smooth and sort of glossy-like in texture. Again, you see it here. So this looks like it's over the, I can't tell. Looks like it might be over the folds, or I can't tell if it's the back of the elbow or if that's the back of the foot. But either way, here you see lichenification over, and notice how the lichenification is superimposed over this sort of erythematous like plaque region of dermatitis. And a lot of times you'll see these like sort of lines that cover it like this. You see these sort of like parallel lines. That's characteristic in lichenification. You see lichenification here along the toes and then over the ankles. This is that dirty neck appearance that you get in adults, and this is amyloid deposition. So it's just this sort of brown kind of ring that goes along the neck. You can see it more prominently in lighter pigmented individuals, but you can also note it in darker pigmented individuals. It'll just be darker than the rest of the skin. You also see in this patient that there's some lichenification here too. For diagnosis, this is a clinical diagnosis. Really, our labs are useless for diagnosing atopic dermatitis, but because atopic dermatitis tends to happen in conjunction with other allergic diseases, you may want to consider at some point doing these more specific allergic tests that can help you determine whether there are known predisposing allergens. So that may be something to think of down the road, but if you're just making the diagnosis of atopic dermatitis and going on to treatment, which is typically what you're going to be doing working in a clinic, it's like we had in this patient, we want to know, is this atopic dermatitis? If so, yes, treat it. You don't need to do any kind of laboratory investigations. So there are various criteria for atopic dermatitis, but really none of these are perfect. So this is the one that I got out of a textbook, a dermatology textbook. So it's one must-have and then 3 or more of a long list. So the must is obvious. I already told you the sine qua non is pruritus. If it is not an itchy rash, it is not atopic dermatitis. Then you need to have 3 or more of the following. So a history of involvement of the skin creases, and the skin creases can be the antecubital fossa, the popliteal fossa, the fronts of the ankles, the neck, around the eyes, and then a history of generally dry skin in the past year. That's going to be hard to elicit, but it's really subjective. Onset under the age of 2 years, and then visible flexural dermatitis. This criteria, this sort of criteria for diagnosis is really more useful for adults, I guess, but this is one of them that I found. For the test, just know the characteristics of atopic dermatitis. You don't need to fit everything into an official criteria. This is just one of them that I found. What is our differential? Usually, eczema is going to be pretty straightforward, but there are some other things that you want to consider. We already talked about one of them, and that was Fifth's disease. And Fifth's disease is going to generally have symptoms that preceded the rash and then the rash came up afterwards, it also is going to be a one-time deal, and then you're not going to get it again. Some other things, so when we're thinking about really young children, babies, seborrheic dermatitis is a big one. So seborrheic dermatitis, that's cradle cap. It occurs over the scalp. It can also occur over other areas, particularly the intratriginous areas. Seborrheic dermatitis looks a lot like atopic dermatitis, and so it can be very difficult to differentiate early on. But if seborrheic dermatitis is over other areas, it does not tend to spare anywhere. So it is most prominent on the scalp. It's very common to the point where we have a specific name for it called cradle cap, but it doesn't really spare any areas. And so you may see it over the diaper area, you may see it over the nose. We don't see that characteristically with atopic dermatitis. With seborrheic dermatitis, it tends to go away on its own, and it never goes into that chronic stage where it lichenifies. But overall, this can be very difficult to distinguish early on. So I would look for things like family history, and then to see how much this progresses. Typically, this will go away on its own. Psoriasis, there's a lot of, it can be very difficult to distinguish the rash of eczema or atopic dermatitis from the rash of psoriasis. It's a very similar appearing rash. The difference is psoriasis is more a disease of teenagehood and adulthood, whereas atopic dermatitis is more of a disease that comes on during childhood. So psoriasis, you see an older age of onset. It is an itchy rash. It is erythematous, maculopapular, looks just like looks just like eczema. The difference is that the pruritus will tend to be accompanied with burning and more pain-like symptoms, whereas with eczema, it's just itchy. It's not a painful rash. Psoriasis is also can affect the nails and the lips. We don't see that so much with eczema, and it does not come on during infancy. You do not see psoriasis in infants. I mean, I suppose theoretically you could, but it just does not happen like that. Whereas with eczema, it has a tendency to occur as a rule during infancy or toddlerhood. So hopefully you can distinguish those two. But the rash, it looks just almost exactly the same. So you're going to distinguish this based on the nature of how it feels. Is it itchy? Does it hurt? Does it burn? Where it occurs and how old the patient is and when it started. Contact dermatitis, this is like poison ivy, poison oak. So this is, you're going to figure this out based on the history. If there was recent exposure to an allergenic source, you can get nickel allergy, you can get allergy to certain things that are in like detergents and soaps that you use for washing your clothes. With contact dermatitis, it will you'll have exposure to the source, and then that will be followed by a rash in 24 to 48 hours. This is your typical type 4 delayed hypersensitivity reaction. It will self-resolve after withdrawal, and it will never come back. Now, when you're considering a patient with eczema, you need to ask what kind of detergents are you using? Have you switched detergents lately? Another good one to ask is if you're giving the child new clothes, are you washing them beforehand? A big problem is when you put on clothes for the first time, a lot of the chemical products that are in those clothes, they can cause contact dermatitis. So formaldehyde is one. So it's always good for parents to wash clothes that they buy that are brand new, to wash them first because it can have chemicals on them which can cause the contact dermatitis. Ichthyosis vulgaris is not common, but it is genetic. It's autosomal dominant. It looks similar to atopic dermatitis. It presents early but not at birth, but this will persist. This will not come and go so much. The severity may increase or decrease, but it will not completely resolve ever. It is dry and scaly skin, but there's going to be less erythema and you won't have papules. So this, again, it can be a difficult differential, but note the genetic linkage and that it does present early but not at birth, and it's more persistent than atopic dermatitis. Atopic dermatitis tends to be more more episodic in nature. Scabies, this is a big one because it's common. So here, look for other affected family members and contacts. This is acute onset, so you're not going to have a history here. There's a tendency for this to occur on the webs of the fingers, also on the hands and feet, and in the genital area, not on the face and on the scalp, which is more common with eczema. So look for the acute onset. So you have a 5-year-old who's never had rash in the past, but now has rash on the fingers and hands and toes. That's more consistent with scabies compared to if you have a 9-month-old who's had episodes of rash. If you look really closely with scabies, you'll see those linear burrows and stuff, but that can be difficult to appreciate. Wiskott-Aldrich syndrome, we already talked about that. This is accompanied with immunodeficiency and thrombocytopenia. So look for a history of nosebleeds, bloody diarrhea, which are linked to thrombocytopenia. This will only occur in boys. It's X-linked. Cutaneous T-cell lymphoma, not going to happen in really, really, really young children. But often this is misdiagnosed as atopic dermatitis very early on. It is rather indolent. It will progress over several years. This can be a very difficult differential. I don't expect you to get asked about this on the test, but what will happen is with cutaneous T-cell lymphoma, typically it will be diagnosed as atopic dermatitis, and it responds to all the typical symptoms or all the typical treatments of atopic dermatitis, but it will progress ultimately into, it really depends, but you can get these areas of hypopigmentation, you get lymphadenopathy, in some cases you can get leukemia, that's called Sézary syndrome, and all the symptoms of leukemia, so all the drops in all your white count and red blood cell count and everything. But the rash will persist, whereas with atopic dermatitis, it doesn't persist. It's more episodic in nature. I don't expect you to get asked about this. This would be very difficult to put into the form of a vignette. But you can get cancerous-like manifestations in addition to your skin manifestations. What do we do for management? The cornerstone of treatment, and this might surprise you, is topical moisturizers. Now, a lot of people would think that you want to jump to using topical corticosteroids. Why? Because we use corticosteroids for all sorts of skin diseases. And in particular, when you think of allergic disorders, you think of steroids. We use corticosteroids for allergic rhinitis. We use corticosteroids for asthma. Why not for atopic dermatitis? And we do use corticosteroids, but if you have somebody who's coming in with mild atopic dermatitis and they've never been treated before, the first thing you're going to go for is topical moisturizers and some good skincare advice, because that is not associated with any adverse effects. It doesn't require a prescription, and you don't have to worry about the patient misusing the prescription. So topical moisturizers. This includes emollients as well as occlusive agents. And so what do we mean by that? Emollients are things like glycol, glycerol, stearate, soy sterols. What those do is they lubricate and they soften the skin. And then you also want to use occlusive agents too, and those are things like petroleum, dimethicone, mineral oil, which can be added to the bath. You'll see all these things over the counter. These are marketed. Aveeno has a big long line of things that they put out. They've got a special formulation for babies with eczema. But the occlusive agents, they're kind of like a lotion. They just form a layer over the skin and they prevent evaporation. So remember, you see a lot of transepidermal water fluid evaporation, which contributes to the dry skin. The way you want to use these moisturizers, there's a ton of them. You use them as directed, of course. There's instructions on them. But you want to use these daily, and particularly after bathing and showering. So the thing with bathing, it's really good. I mean, you think about it, you've got a problem with dry skin. being exposed to water is a good thing, but it's only good if you apply your moisturizers after you take a bath. So if you take the bath, put your moisturizer on afterwards. Most of these, like I said, are available over the counter. Make sure that they are products that are free of fragrances and preservatives because these can elicit allergy. And then another thing that you can do if you have a specific area, like along the elbows or arms or legs that are particularly affected, is to do a bath, then apply your moisturizer, and then you can do this wet wrap where you take, so you're using sort of bandages, and you're going to moisturize or moisten one bandage with water, wring it out so it's just moist, not sobbing wet. But you wrap that moist bandage around the affected area, and then you wrap a dry bandage around that area. That's a wet wrap. I'll show you a diagram that shows you how to do that. You can teach patients how to do that. So this is just sort of skin care. You use these moisturizers, and it ultimately is going to keep the skin from drying out and prevent the loss of fluids. And this is also good symptomatically for these areas. Now, on the other hand, if you have acute flare-ups and using these moisturizers is not enough, then you can go to using topical corticosteroids. So topical corticosteroids you should reserve for use when it doesn't respond to moisturizers and skincare alone. You should not jump to this right away. So corticosteroids, they have varying potencies. Anywhere from, they classify these type 1, 2, 3, 4, 5, 6, 7, I believe 1 being the highest potency and then 7 being the lowest potency. Don't worry about knowing the different strengths and everything. It's useful for clinical practice. You can look it up on Hippocrates or whatever you've got. But know that there are varying potencies. The lowest potency is the dexamethasone cream, hydrocortisone acetate, which I believe you can get over the counter. And then very high potency, that's clobetasol and difluoxacin. And then there's everything in between. Usually you will use something in the middle for the acute flare-ups, but what you want to do by principle is to use the lowest effective potency and strength. Now, in patients who have frequent flare-ups, you can use topical corticosteroids as a over the areas that tend to get flare-ups. You can use that sort of prophylactically. Just make sure you're using the lowest effective strength and potency. Also, another big thing with corticosteroids, topical corticosteroids, you will never use them on the face. So you have a baby with a really bad eruption on the cheeks, not responsive to moisturizers, you're not going to use corticosteroids. You're going to use these calcineurin inhibitors. So calcineurin inhibitors are things like tacrolimus and pimecrolimus, and these are useful for the face. So you will apply these ointments on the face. And the reason is because corticosteroids, they can cause skin atrophy, and that can be cosmetically disfiguring if it's on the face. If it's on the back of the legs or on the arms, it's not so much a problem. But on the face, it can be really problematic. And I believe part of the reason behind that, too, is that the skin is thinner on the face. And indeed, if you give corticosteroids to, topical corticosteroids to older adults, 60, 70 years of age, older, they tend to have more problems as far as skin atrophy with these topical corticosteroids. Symptomatic therapy with oral antihistamines can be useful. Topical antihistamines have not really been shown to be effective, but you can give oral antihistamines for children that are having difficulty with itchiness, especially if it's at night, which it tends to be, that the itchiness is worse at night, so you can give them children's Benadryl. That can be useful. There's other things like these tar preparations. I haven't seen anything in the literature that shows that that has been useful. However, I have seen some things that you can use these tar preparations for the scalp, but I'm not sure about that. Other things that you can use are you're really refractory to all of these things, I have seen UV phototherapy in the literature as a possibility. Also, I've seen methotrexate, but at this point, you're getting way beyond where you normally respond. Most patients will respond to topical moisturizers, symptomatic therapy. At worst, you need to use corticosteroids and calcineurin inhibitors. Okay, so this is just general management. Every patient, it's going to be different. You can't just say that one therapy is going to work for everybody. It doesn't. Some patients will respond just to minimal therapy. Some are going to require more intensive therapy. And the therapy that you use may change over time. So you may, with really younger children, 5, 6, 7 years of age, you may need to do prophylactic topical corticosteroids to prevent these frequent severe eruptions. Whereas as they get to be older, you might just need to do moisturizers and skincare. So it depends on the patient. Complications, adverse effects of the medication. I already talked about topical corticosteroids. You can get skin atrophy. Other things, there is a potential for systemic absorption. Remember that children have more surface area to weight. So if you're using some of the stronger corticosteroids, there is a potential for systemic absorption, which ultimately can affect things like growth and their hormonal axis. That's not going to be a problem in the lower. So generally the ones that we prescribe, 7654, with the lower strength, lower potency corticosteroids, typically that's not going to cause significant systemic absorption. So as long as the patients are taking these as advised, you won't see significant enough systemic absorption to the point where you've got major problems. If you are using these too much, though, you can get some of these adverse effects. So striae, purpura, telangiectasia, systemic absorption. Hypersensitivity is a rare but documented effect of some of these ointments. So keep an eye out for that. The calcineurin inhibitors, these typically have a pretty good profile. You can get application site stinging and burning, particularly with the ointments. Malignancy has been documented, lymphoma, skin cancer, I believe it's melanoma, but I'm not sure. But it is rare. The only reason that they put this up as a black box warning for these calcineurin inhibitors is because a lot of physicians were using this off-label or prescribing it to really, really young children and just going on with it willy-nilly. You have to use this a lot and usually use it more than directed to get malignancy. But it is a possibility, and so I bring it up here. Infections are a common morbidity in atopic dermatitis. You need to keep an eye out for this. Anytime a patient has an atopic dermatitis flare-up, you want to look for signs of infection, namely infection from Staph aureus. So this can manifest as boils. It can manifest as impetigo, where you get that honey-crusted sort of discharge, and then cellulitis. And this should be clinically straightforward based on the presentation, but you should consider cellulitis. If cellulitis will not look a whole lot different than an atopic dermatitis flare-up, but what you will note is that there is the redness is going to be warm to touch, and it will be painful. Atopic dermatitis should never be painful. If you press on an eruption of eczema, if you press on it, it will not elicit pain. But if it is cellulitis, it will elicit pain, and it will be warm to touch. And so that's how you can differentiate the two of them. What do? We get a culture of the affected area always, and then you will treat this as if it is not MRSA, but you get your culture to see if it's MRSA. So 2 weeks of cephalexin, bleach baths, which I'm going to talk about in a little bit, and intranasal mupirocin. So if you get the culture and it comes back as MRSA, then you can use vancomycin or any of your anti-MRSA drugs. So I believe that's all I want. Oh, yeah, the bleach bath. Okay, so with the bleach bath, what this is, a lot of people think, oh, that's crazy. Why am I going to dump my child with bleach? It is actually effective, not only at treating existing infections, but at preventing infections. So all this is you take, I'm not sure how many gallons, but if you fill the bathtub up to what you would normally get into the bathtub at, so if a full bathtub, I believe it's like 40 gallons of water, but don't quote me on that. You use half a cup of bleach and then mix it. If it's a quarter, or if it's a half bathtub full, then you use a quarter cup of bleach. So that's roughly the dilution that you want to use. And then just make sure that you don't get the water in the eyes and stuff like that. But use that bleach water to wash the child or yourself if you're an adult. I am not sure to what degree you would want to use this in really, really young children, but the studies I've seen that have demonstrated the efficacy of bleach baths have included people all the way down to 6 months of age. So that's a bleach bath. So you can look that up if you want to get more information on that, but that has been demonstrated to be effective for infections. You only need to do the bleach baths, I believe, 2 or 3 times a week. Okay, so another possible complication is something called Kaposi varicella eruption, or otherwise known as Eczema herpeticum. And this is characterized by a sudden eruption of painful erythematous and edematous pustules. These lesions tend to be umbilicated, which then will progress to these sort of punched out erosions. This will get worse over about 7 to 10 days, and it will eventually go away on its own. It can be associated with systemic symptoms such as fever, malaise, lymphadenopathy, and this is typically associated with a disseminated herpes simplex 1 infection. But it is not as bad as it looks, and it tends to go away with time. So, like I said, herpes simplex virus 1 tends to be the cause. So the eruption itself will tend to be over affected areas where you already have eczema lesion. It can spread to healthy skin, but usually it will get better before that. It can also be caused by HSV2. It can be caused by vaccinia. It can be caused by CSV-A16. So there are some other viruses that can cause it, but it's most commonly caused by HSV1 as a disseminated infection. What you want to look for if you see these lesions is bacterial superinfections, and then also do keep an eye out for keratitis. Remember, you can get herpes keratitis, and this is not caused from the eruption. This is caused by the fact that that when you have eczema herpeticum, and then if you have eczema herpeticum, it means that you probably have a disseminated herpes virus infection, and that can lead to HSV keratitis. And so if you have a patient presenting with the eczema herpeticum and they have ophthalmologic symptoms like a change in visual acuity or photophobia, that patient should be urgently referred to an ophthalmologist. For treatment for the KVE infections, you can just do acyclovir, and it will typically respond to that. If it doesn't, you can use foscarnet. Foscarnet is also what you would want to use if the patient happened to be immunocompromised for one reason or another. So this is how you do the wet wrap therapy. I've already talked about this. This is something that you can do for anybody who's got recurrent flare-ups in a certain area. So you soak the wraps, which I guess they make like these wraps for babies where you can do their whole skin. But you soak it in warm water, you wring it, so you don't want a soaking, dripping garment here. You soak it in warm water, you bathe the child, then apply your lotion, your moisturizer. Make sure that you want to make sure this is damp, not soaking wet, and then you apply that on the top. Okay, I don't have children, so My advice to you is as best as I can give it. For prognosis, the symptoms will tend to improve with age. Uh, and then what I have found in the literature is that living in southern states, having a relative with atopic illness, and then exposure to these various allergens are linked to more persistent symptoms. That would make sense. If you are exposed to allergens, then you're going to have more flare-ups of your eczema. As far as long-term care, just good skin care. So making sure that you are taking baths and then using your moisturizer, minimizing your exposure to allergens is all good for preventing flares. So if you have any questions about any of the things we talked about here, go ahead and write me a comment below, and I will see you next time.